Unfortunately, kidney damage is somewhat common in America. The CDC reports that more than 1 in 7 U.S. adults have chronic kidney disease. In the early stages, your kidneys may seem to be functioning like normal. As the condition progresses, you might feel symptoms such as nausea, muscle cramps, and swelling around your feet and ankles. If the disease is left untreated, you could end up needing a transplant as your last option. However, it is possible to prevent kidney disease altogether. Dr. Latanza Adams, a clinical pathologist, says the two main culprits to keep in check are high blood pressure and diabetes.
High blood pressure really is the silent killer because so many things can be going on. And by the time you start having symptoms, by the time, you may have nonspecific symptoms of like, oh, I'm seeing dots, or, oh, I get a little lightheaded. By that time, your pressure is already elevated and you're doing damage to your kidneys. And the thing to remember is that you can't get that back. So glomerular filtration rate, there's little units in your kidneys called glomeruli. And that eGFR measures how those little units are functioning. And as your GFR goes down, that means those little units are dying and you can't get those back.
eGFR is a blood test that doctors use to diagnose and monitor kidney disease.
eGFR stands for estimated glomerular filtration rate, and it's basically the amount of blood that filters through the kidney every minute. And so you can use that number, the filtration rate, as an estimate of how well the kidneys are working, how well they're filtering your blood. And in patients who have mild to moderate to severe kidney disease, they ultimately have lower and lower eGFRs.
That's Dr. Jonathan Gensen, professor of clinical pathology at the University of Utah and chief medical officer at ARUP Laboratories. He says eGFRs help show which stage of kidney failure a patient's in and what treatments are needed. However, the test has different threshold requirements depending on a patient's race.
So there are certain aspects of diagnostic testing that historically have used things called race adjustment factors. And they may have been integrated into equations in some cases long ago because of observed population differences and biological factors, concentrations of things that may be found in the blood. One of these is creatinine,
which is produced when muscles break down or can come from certain foods in your diet.
And long ago, there were some small studies that suggested some small population differences in creatinine specifically between Black African American versus white populations.
They felt that African Americans had much more muscle mass. And so they had to put this factor in there, which caused, saying they had all this muscle mass, they had to put the factor to account for the creatinine and things of that sort.
Ironically, the race adjustment factors, I think, led to some unintended consequences for the results on kidney function testing.
Gensen says there were a couple of issues with the initial research, the first being that the study populations were too small to accurately represent an entire group of people. The second problem was that scientists assumed the same biological principles would apply to every person in such a large category.
The differences between individuals are far greater than the differences than you see between populations. So that systemic bias comes into play because you're treating all people of a population in some ways the same and trying to adjust for that, even though the differences between you and I are much greater than what you would see in differences between populations.
So even though the racial adjustment factors were set with good intentions, they ultimately produced inaccurate results for the Black population. Adams says the adjustments have caused a lot of harm.
It overestimated African Americans' GFR. So where that became problematic is that it made African Americans appear less sick than what they really were. And you would have someone presenting in a situation where they would truly benefit from having a transplant or certain medical interventions, but because of this GFR, they didn't meet the criteria because it was too high and it wasn't low enough, but they met everything else but this GFR number.
And when the adjusted test results finally showed that there was a problem, many patients were too sick to withstand a kidney transplant.
You have to look at the whole picture and can't just say, well, they got this muscle mass and, we'll just do it just for them. Because then it brings up a larger thing, like, what about people who identify as African American but come from a multicultural background? How does that play a role? So it's too many factors in doing that. You can't just assume that what works for one works for all, I suppose.
Fortunately, there's been a recent push to help eliminate these disparities and finally get accurate results.
There's been a pretty strong movement to identify the circumstances where those types of adjustment factors are being used and then evaluate whether they are truly necessary and eliminate them when they are not and when they may be introducing systemic bias.
But the answer isn't as simple as just getting rid of the race adjustment factor from the EGFR equation.
Initially, people thought, well, just remove the factor and it'll be fine. Not necessarily, because then you want to make sure it doesn't skew results in another direction.
What was shown in really a landmark paper last fall was that just removing the correction factor alone was not sufficient, that they refit the equation to a larger, more representative data set. So it's actually a new equation. It's similar in a lot of ways, but it is a new equation.
And while this new equation does not include any adjustments based on race, there are other corrections for factors such as age.
The older that you get, you do see changes in creatinine concentrations. And so there are adjustments for that. And I think the community believes that that's applicable as well. The equations do have adjustments for male versus female patients because you do see differences in creatinine concentrations between those two groups as well. But it eliminates an adjustment factor for race. And that adjustment factor for race actually made the EGFR results look healthier,
which would delay the diagnosis of kidney disease, a problem that Adams is all too familiar with. As a teen, she watched her father unknowingly struggle with kidney failure.
So he started acting peculiar, started acting a little different, and couldn't remember things. He just seemed off. And he also had hiccups. Really bad. I mean, they wouldn't stop like for days. It was pretty impressive. So it was just like all these different things that were going on with him. And my mom was just saying something isn't right.
And though their friends tried to blame the strange behavior on his recent stroke, Adam's mom knew something else had to be going on. Unfortunately, he was never able to see a specialist, and Adam says his primary physician refused to take his symptoms seriously.
We were in Chicago, and he just did not look well at all. And we took him to the University of Chicago ER, and they ran some tests and immediately they said, your husband is in end-stage renal failure. We have to do emergency dialysis on him. So they prepped him, took him to surgery and put a fistula in his arm and started dialysis immediately. That's how bad it was. And those hiccups that he had, it was because his diaphragm was irritated due to all the toxins in his body. And that's why he was acting so weird and so off and just different.
But even with the emergency action, her father's condition was too severe for him to make it through surgery. Sadly, Adam's story is not uncommon. But this new EGFR equation is a step to ending these oversights. Because of its importance, Gensen and his colleagues conducted a study to see how fast clinical labs across the country were adopting the new equation.
Many things in medicine take a long time. They don't happen quickly necessarily. And with the new equation that came out, it was the end of last September 2021. There was subsequently a guidance publication that was published to help laboratories in some of the details about how to change to the new equation. But within 6 months of publishing the equation to begin with, over 30% of the labs that we surveyed had already switched, and another 30% plan to switch by the end of this calendar year as well.
Which Gensen says are very encouraging numbers.
I was actually surprised that we already had 30% of labs that had adopted the new equation. I thought that was incredible progress. But it shows the, I think, attention to trying to do the right thing in the clinical lab community, the attention to trying to treat all patients equally, and the focus on providing accurate results. And that's something that's just part of the clinical lab community. It was nice to see that.
The team is planning to conduct a follow-up to this research, published in JAMA early next year, to monitor the progress.
One of the reasons why I think we believe the new equation and our own study findings are so important is that this type of testing for creatinine is included in a large number of common laboratory testing panels. So the scope of this and the recognition of kidney disease based on eGFR results, I think, is pretty wide-reaching. And it's one of the reasons why I think this new equation is so important, because it can impact so many patients in so many settings.
For the labs that have yet to adopt this new equation, Gensen says it's usually an issue of resources.
The equation does take programming within it's called the laboratory information system, or an electronic health record, and those have to be programmed correctly and validated correctly to make sure that they work right. And that may take resources that are even outside the department. I think what we really care most about is that people get on track and get on target to adopting the equation when it works as soon as possible for them, but also in a way that we know is validated and done correctly.
For patients that are about to get an eGFR test, Adams advises them to reach out and make sure they're receiving the updated equation.
You can call the lab and ask, or call your doctor and ask them, and they can just call the chemistry department and ask, have you all implemented the new estimated glomerular filtration rate equation? And they should know. Don't be afraid to ask questions, because any good physician out there will answer those questions. And if you don't understand, say you don't understand. And if that doctor gets frustrated with you, maybe you can see another doctor.
Adams says many people can also check their online lab results to see which eGFR equation's being used. You can find more information about Drs. Latanza Adams, Jonathan Gensen, and all of our guests on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. I'm Reed Pence. Coming up next week on Radio Health Journal.
We really don't want people walking up and down stairs with laundry baskets full of clothes, and, that's a nightmare waiting to happen.
Your home could become a hazard as you age.
Then the struggles of air travel for passengers with disabilities.
I have to dehydrate myself 24 hours before I even attempt to get on that plane to hope that I don't need to use a restroom while I'm on that flight.
All that and more on Radio Health Journal.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
It was incredibly dehumanizing and demoralizing for the woman giving birth.
Imagine being strapped down during labor. Uncovering what female inmates go through when giving birth behind bars. Then,
how do we as people help nature adapt to our changing world? And I would argue there's a few different things we can do.
The fight to slow the extinction of Earth's species. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.